Okay, and then I mentioned earlier on the idea of using historic controls. And again, this is a recent idea that we might be able to use electronic health records to provide controls for current randomized trials. So if you imagine that you've got let's say that there's a population of people with cancer, and we've got a new treatment, but which we think possibly doesn't work well for everybody with the cancer, but might work on a small subgroup of people who are red. If I do a standard randomized trial in everybody with the cancer, then the clinical effect size that I see will be small, because the drug's only going to be effective in a small subpopulation. Yeah? So I could do my big randomized trial, but it isn't going to be that useful. What will be much better is if I can do a randomized trial where I only include the subgroup who I think might benefit. But the problem is, they might be a very small group of patients, and it might take me a very long time to recruit enough patients to do a randomized comparison against either the next best treatment or no treatment, whatever it happens to be. It's possible, if the data exist, that I could use patients that look like these red patients, but maybe 3 or 4 years ago, when this treatment wasn't available, if I've got the right kind of data. There are lots of considerations that we need to be careful about if we're going to do this. So we need to be careful exactly who we would compare with, what sorts of patients were they, are they easily identified from a data source that already exists. And it would be really important that we capture all of the relevant information for those patients, such as what disease stage they were at, what their outcomes were. So this is not straightforward, but it's the sort of work that people are doing to see whether we can use historic controls to use as the non-treated comparator arm for current day randomized trials, if that makes sense, or controlled trials. So it would be quicker because more eligible patients are treated, which then means that potentially new useful treatments can be given to a wider group of people quicker. But there is a risk that we will get the wrong answer because we're relying on this previously recorded information, which may not be perfect. Okay, so to summarize, so we know that electronic health records are being used more and more. We've got some very large data sets from all sorts of regions of the world. I should also mention that there are, of course, big regions of the world where these data are not available. And if you're working certainly in lots of countries in Africa, for example, it's very rare to be able to access data on this kind of scale. And in fact, the treatment effects you might see in some of those countries could be very different for good reasons. And we won't be able to answer questions on them until we've got access to better data in more regions. Our understanding of how to make the best use of these data is at different stages depending on the sorts of research questions we want to ask. So we have well-established methodologies for looking at drug utilization and to estimate the risks associated with taking drugs. Where we are still finding out the best methodologies and whether or not they're appropriate are areas like signal detection, looking at the effectiveness of treatments, doing randomized trials within databases, and also using historic controls. Okay, so I've got a range of references there that you might find useful.